The following podcast is part of a certified educational activity titled Changing Times in DLBCL, Oncology Nurse Insight on the Practicalities of Antibody Therapy. Access the entire activity and complete the post-test at peerview.com/DFX860. Downloadable slides and practice aids are also available.
Hello, I'm Leslie Camille Balance from the Sarah Cannon Cancer Center in Nashville, Tennessee. Today I'm pleased to be joined by my colleague Amy Goodrich from the Cancer Center at Johns Hopkins in Baltimore. You're about to view an educational program based on a virtual symposium held during the ONS Congress on Novel Antibodies in Diffuse Large B-cell lymphoma. Since that program was originally developed, there's been a new FDA approval, and Amy and I will spend a few minutes providing you with an update. Now I'm going to turn it over to Amy to talk a little bit more about LONCA.
Thanks, Camille. So in looking at new antibodies with FDA approval in diffuse large B-cell, we will be talking about Tapacidomab and Polatuzumab Bedotin later in the program. The one we're really trying to focus on now is LONCA, loncastuximab tesirine, which is a CD19 antibody conjugated to a potent PBD dimer. And this was just recently FDA approved for use in relapse refractory large B-cell lymphoma for folks who have had at least 2 prior lines of therapy. And it includes your de novo diffuse large B-cell patients, those arising from low-grade lymphomas as well as high-grade B-cell lymphomas. In looking at the dosing of LONCA, this is an IV infusion. It's given over a half hour on day 1 of each cycle. And it's given every 3 weeks until progression or intolerance. And the recommended dosing, as you can see, is 0.15 milligrams per kilogram every 2 weeks for the first 2 cycles, and then 0.075 milligrams per kilogram every 3 weeks for subsequent cycles. Patients do require steroid pre-meds beginning 3 days prior to therapy, and there is a downloadable antibody dosing practice aid for nurses for this. In looking at safety monitoring, some of the unique adverse events, this issue of effusions and edema, you're monitoring for pleural effusions, pericardial effusions, ascites. You can see the list there, and patients also need education on what they're looking for. Severe effusion and edema happens rarely in about 3% of patients. If it does happen, you would work it up just as you would with any other situation, getting some imaging and manage as clinically appropriate. Cutaneous reactions are another issue to be aware of, monitoring for new or worsening rashes or cutaneous changes. Photosensitivity is an issue with this drug as well. And derm consults can be considered or appropriate for some patients. So like many of the drugs we give to these patients with diffuse large B-cell lymphoma, myelosuppression is an issue. About 50% of patients will develop grade 3 or higher neutropenia, about 20 to 30% thrombocytopenia, only about 12% anemia. And fortunately, there's only a 3% incidence of febrile neutropenia, but that is something that our patients need to be aware of as well, and always looking at the package insert to figure out when to hold or dose reduce or discontinue. And then again, a common theme with this set of disease, with this disease, is infection. Occurs in severe infections in about 10% of patients. So that's something we're always monitoring, teaching patients about, and jumping on quickly to treat promptly.
Thank you, Amy. So that concludes our update. Please continue on to the main program, where you'll find more information on the emergence of novel antibodies in diffuse large B-cell lymphoma and the practical steps that nurses can take when managing patients on antibody therapy, particularly patients with relapse refractory disease.
Hello, and welcome to Changing Times in DLBCL, Oncology Nurse Insight on the Practicalities of Antibody Therapy. Today's panelists include myself, Leslie Camille Balance, Amy Goodrich, and Jill Lazinski. So we're going to start with an overview of diffuse large B-cell lymphoma. It is the most common non-Hodgkin's lymphoma in the United States. It accounts for 30 to 40% of non-Hodgkin's lymphoma cases, with approximately 18,000 cases per year. It's typically aggressive. It presents with rapidly enlarging lymphadenopathy and constitutional symptoms. There's also a high frequency of extranodal disease, so many patients will present with bone marrow involvement or, testicular involvement or skin involvement. The incidence of diffuse large B-cell lymphoma does increase with age. So most patients are over the age of 60 at diagnosis, and the median age at diagnosis is between 60 and 70 years. Diffuse large B-cell lymphoma can include painless or rapid swelling in the neck, underarms, or groin caused by enlarged lymph nodes. They may be painful for some patients, and they can have things that we call B symptoms. And this is night sweats, fever, and unexplained weight loss. These are fevers that are not linked to an infection. They can happen every afternoon randomly. And the night sweats are drenching. So they're drenching through their clothes, they're drenching through, the sheets. And the patients are just, a lot of times, when they present, they're declining. They're just they're not feeling well. They're not eating well. The weight loss, the weight's coming off pretty quickly. And many times they'll present with a fair amount of pain. So there's a spectrum of DLBCL subtypes. They're not all created equal. So in this chart that you see, you've got different classifications. You've got germinal center lymphoma and non-germinal center are common subtypes. Germinal center patients typically have a better outcomes, except for the sort of the gray circle in the middle and the green circle. So the gray circle, there is a double expressor lymphomas, and those are a little bit more aggressive. And you usually see an overexpression of something called MYC and BCL2 on immunohistochemistry. So with double expressor lymphomas, we sort of see that on the first pathology reports. In the green, we've got our high-grade lymphomas. You'll see it's high-grade lymphomas, and that is double and triple hit, which we'll get into in a minute. And those are really the most aggressive, and they actually require different frontline therapy. So double and triple hit, they're pretty challenging. They have a tendency to be quite resistant to chemotherapy. They can be. And these, we don't know for sure whether the patient has them until we get the FISH reports. So until we get the more advanced sort of genomic reports that come a week or two later, you'll see rearrangements of MYC and BCL2 or BCL6 for double hit lymphoma, and for triple hit, you'll see rearrangements of MYC, BCL2, and BCL6. They have very poor response and outcomes with R-CHOP. So we usually give our EPOC in the front line. So some DLBCL patients are at high risk for CNS relapse. These are patients with extranodal sites like breast, testes, uterus, spine. They're going to be at high risk for CNS relapse. You also, patients with IgM secreting diffuse large B-cell lymphoma, intravascular B-cell lymphoma, or of course the double and triple hits that we just talked about, or kind of when they have a high risk score. There's different ways of preventing. These patients may need CNS prophylaxis, and that can be, intrathecal chemotherapy or systemic chemotherapy. We use both depending on the patient at my particular clinic. Amy, do you guys use more systemic therapy?
Yeah, and so I think you're talking about that day 15 methotrexate during their CHOP cycles. We use both. It really depends on the patient, because these folks tend to be a little older. Their kidney function is not always the greatest, and so they tend not to tolerate that methotrexate very well. They tend to have a bump in their creatinine. So that's what we try to use, but clearly not everyone is going to tolerate that. So we do end up using intrathecal prophylaxis on a fair number of patients.
We do too. We do both. We've had actually over the past year a swath of, I would say, men that have the testicular involvement, we've had 4 or 5 of those patients. And so, and neither of them were double or triple hit. So they got R-CHOP and then they're getting day 8 systemic methotrexate. So they go into the hospital on day 8.
Yeah.
So, yeah. So that's, but you're right with the kidney involvement, because sometimes even their kidneys are fine. You know, it's a balancing act for sure. And if they don't clear their methotrexate, they're in the hospital for several days. Do you guys admit for that, or do you do it outpatient?
For the methotrexate, we definitely admit. And so as we're talking about this, you can, hopefully the audience can tell that there really is not a gold standard for how you do this, because Camille is saying they do day 8, we do day 15. I don't think it really matters.
Right.
And there's no magic number of cycles or, you know, agreed upon intrathecal number of doses. So it's, I mean, I think the point is we try to get at least 3 into people. If we can get 4, 5, 6, that's great. But based on tolerance, you may or may not be able to do 1 every cycle, whatever you're using.
Right. So here's some tools for capturing DLBCL prognosis. This are, you know, risk. You've got age. You know, as patients age, their risk goes up. If they're in more advanced stages, so the Ann Arbor stages 3 or 4, they would get a point for that. If they come in with a poor performance status, so if they're already not looking well, you know, they're going to be harder to treat. They're not going to tolerate the therapy as well. If they have a pretty high LDH, then that sort of ups their risk factor, and or if they have extranodal disease. So they have, you know, so at the table at the bottom, you can see that if they have none of these, they have very good risk. 1 or 2 of these factors is good risk, and 3 or above, then they're poor risk. Okay, so the treatment landscape of diffuse large B-cell lymphoma now includes novel antibodies and cellular therapy. So, you know, frontline therapy is usually R-CHOP unless they're double or triple hit, in which these patients do much better with R-EPOCH. 60% are cured, which is great, but then we have 40% of patients that have relapse refractory disease, so they're going to need second-line therapy. So with our fit patients, you know, we typically give something that we call a salvage regimen, which is usually a platinum-based multi-drug therapy. We usually give rice for about 3 cycles, and if they're in a complete remission, and if they can tolerate the rice, because it's definitely harder than our CHOP, then they go on to stem cell transplant, autologous. If they don't, if they don't tolerate it, or if they relapse, because we have seen patients that, you know, they may get an initial response to rice, and then when we're doing the transplant workup, it's come back. Then we try to get them on CAR T therapy, either commercial, which can be, we have, but sometimes it's a little bit challenging with some of the financial insurance situation, or a trial. A lot of times we put somebody on a trial. So, but for our less fit patients, we know, and especially we know if we had a hard time getting them through frontline therapy, then we know that, giving them salvage therapy in a transplant is not really going to be an option. It's going to do them more harm than good. So this is where the role of novel antibodies come in, and where, where we can get some good control of their disease and hopefully give them quality of life. Amy, what do you guys, is that about, that's what you guys do? And
yes, it is. It really is. We do a lot of non-myeloablative allogeneic transplants too. So, there are a few other options, but really it's about who's likely to be able to tolerate more aggressive therapy and who isn't.
Right. So new antibodies with FDA approvals in DLBCL include Tapacidomab, which is a CD19-directed antibody. This is approved in combination with lenalidomide for adults with relapse refractory DLBCL, not eligible for autologous stem cell transplant. There's also Pulatuzumav Bedotin, and it's a CD79B antibody conjugate to cytotoxin MMAE. It's approved in combination with bendamustine and rituximab for adults with relapse refractory DLBCL after 2 prior therapies. So now we're going to get into changing evidence and changing treatment, perspectives on newer antibody strategies. So here is our case patient. This is Nathan. He is a diffuse large B-cell lymphoma patient receiving chemoimmunotherapy. He is 68 years old when he was diagnosed. He has stage 4 because he had bone and liver involvement, IPI 4. His past medical history includes atrial fibrillation, diastolic dysfunction, and moderate COPD. He was treated with frontline therapy with R-CHOP for 6 cycles. However, unfortunately, he relapsed 9 months post initial therapy. So he is not eligible for transplant, and he's concerned over next steps. What is the role of the nurse in educating this patient on treatment options and answering questions that he has about requirements? Amy?
Right. So, Camille, so this guy is clearly not going to get to autologous transplant. He may be eligible for CAR T or something down the line, but he's somebody who, has a lot of comorbidities. And so really it's going over all of the treatment options with him. And I know that we'll be talking about this, but what is the administration schedule? What are the visit schedules? What are the side effects? Because most people are worried about how it's going to impact their life and how it's going to impact their quality of life. And most folks are really coming at it from not wanting to burden their social system and staying as independent as they can. So those are really the things that most people who have multiple options are really asking about. And so, at this point, and for someone who is potentially eligible or not eligible for transplants or CAR T therapy, some of the counseling that you need to talk about, and this is really sometimes really hard for patients to get their head around, is autologous versus allogeneic stem cell transplants, and just the reason that you do one versus the other. And typically autologous is a very high dose chemotherapy based, so are reserved for patients who are still responding well to chemotherapy, versus allogeneic, which is typically reserved for patients who are not responding well to chemotherapy, so to get that new immune system. And then certainly the stem cell collection for autologous, that's somewhat a foreign concept to patients, that we're going to give them a slug of chemo and then supercharge them with growth factor to get their stem cells out. And then certainly those of you who work in transplant know that the preparative regimens are different from disease to disease, and just making sure patients understand that piece as well. And there are different toxicities for all of these. Certainly infection is an issue with all of them, but graft versus host disease comes in when you're talking about allogeneic transplants. And then for CAR T, the big ones are that cytokine release and the neurotoxicity that patients can have after CAR T, and just making sure that patients understand those things. And then really much of what drives these eligibilities are their organ function and their performance status. And, we're very upfront with patients, like this guy, where, Camille, you alluded to this, that we don't want to harm people. So for someone who's got some cardiopulmonary dysfunction coming into this, just because maybe we could squeeze him onto some trial or something doesn't mean we should. But most of these folks who have these comorbidities, we're not going to offer them transplant, because the last thing we want to do is hurt someone. Right. And then really just the differences of between all these options. And this is an ongoing, this is a continuum, this is discussion point after discussion point after discussion point. You don't do this in one visit, you do this in multiple visits. And then, so looking at second line therapy, it's really, again, largely based on candidacy for autologous transplant. And so you had talked about Tapacidomab and Polatuzumab Bedotin. And if you look at the NCCN guidelines, these are approved for patients who are relapsed and not eligible for autologous transplant. And then CAR T, which we're just starting to talk about a little bit, is approved after 2 or more systemic therapies. And today there are 3 options for patients. We have Axicell, Tisagen, Leclacel, and Lysacel, the third one. And these are in the NCCN guidelines as well. And there are trials going on trying to move CAR T a little sooner in the treatment course for patients. So, trials are definitely ongoing. We're still learning a whole lot about CAR T and trying to do a better job with outcomes. So for this guy, or Nathan, so he is making decisions about his treatment. And when he was on R-CHOP, he really did not tolerate it very well. He had a lot of issues with neutropenia. He had a lot of nausea and vomiting, despite maximizing his antiemetic regimen. He also felt pretty bad. He was fatigued and he developed weakness, and it was a really tough go for him. And then, of course, other R-CHOP adverse events include infection. We're always worried about GI events. Dehydration it can be common with these folks who don't tolerate it well also. So then what we're going to be focusing on with him are the chemo light or chemo free options, meaning Polatuzumab Bedotin with bendamustine and rituximab, or Tapacidomab with lenalidomide. So, he's someone who's not going to tolerate rice and would not be on that aggressive treatment paradigm. So shared decision-making is really important with these folks, and certainly when we're using these novel antibodies. And so it really is important to be an advocate for the patient, to make sure they have information so that they have realistic expectations. And really always this next bullet is reviewing alternative options. And this is something I think that we don't do enough of, talking about palliative care and hospice. But certainly with these older folks with lots of comorbidities, that is always an option for them to just focus on quality of life, because we're likely not curing them or getting them to some therapy that is potentially curative. And then, of course, educating patients and their caregivers on side effects and management. And this has been a little challenging in the age of COVID when folks are coming alone, but, doing this over and over again. We're doing our best. And then really figuring out what their support system is, what they have going on in their lives, who relies on them, is it easy for them to get back and forth? Just really trying to figure out who that person is and how they're making decisions. And then, of course, communicating with other healthcare providers, because, clearly this guy's probably got a cardiologist and a pulmonologist, and just making sure that we're keeping everybody in the loop. So looking at some of the data in Tapacidomab with lenalidomide, this is the L-MIND study, and it was in relapse refractory diffuse large B-cell. So most patients had 1 to 3 prior regimens. They were not eligible for high-dose therapy or autologous transplant, and they were not refractory. So these were patients who were still responding, and the overall response rate was the primary endpoint. So if you look at this, 43% of these folks got a complete response, and 88% of that 40 of those 34 patients were confirmed with PET. And so there was a 60% objective response rate, 74% had disease control. So this was really effective in this relapsed refractory group of patients, and with these folks who were not going to be offered aggressive therapy. So for them to get a complete responses is really wonderful. So this is really promising, and this is something that hopefully we're all going to see moving into our clinics more and more as time goes on and this data continues to mature. And then in terms of the longer term outcomes, we do have 2 years. So after two years of follow-up, the overall response rate continues to be almost 60%. The duration of response, look at that, 34.6 months. And that is amazing to take a group of patients who have relapsed diffuse large B-cell lymphoma and get them into remission for almost 3 years. And then the median overall survival was 31 months. And so the group did recognize that patients who received L-MIND in the second line did better than those who had 3 or 4 other lines of therapy. So, the sooner you use it, the better folks do. So looking at Polatuzumab Bedotin with bendamustine and rituximab, this trial used the 3-drug regimen versus bendamustine and rituximab, again in this autologous transplant ineligible group of patients. And it was a similar N there, as you can see. And so the complete response rate is relatively similar, 40% with the 3-drug regimen versus 17 with BR. The duration of response was 12 months. Which still is excellent for this group of patients. And then you can see there was the longer median progression-free survival and overall survival for the 3-drug regimen, 9.5 and 12 versus 3 and 4. So this is another really good, well-tolerated chemo-light option for these patients. And so Camille, I see we've got a bunch of questions here.
Thank you, Amy. Yeah, there's some great questions. So in your experience, which chemoimmunotherapy is more problematic for safety, R-CHOP or R-EPOCH? So I would say in my experience, R-EPOCH, it's just you add the etoposide in and it really seems to, there's more dehydration, there's just more debilitation, especially in patients, I would say 55 and up. We have a hard time getting it. We can get them through it, but there's usually PT involved. They just, it is rough. R-CHOP, every once in a while we have patients that don't do well, don't get me wrong, but we have a lot more patients that, hardly, have fatigue and poor appetite, and that, that's it. Like, that's very easy to control. What about you, Amy? What have you seen?
Yeah, it really is the same. And I do think that the additional drug is definitely part of it. And I do think that these folks being admitted for several days, and they're on the older side, and that sometimes knocks them out of their regular routine as well. But definitely R-EPOCH is more problematic in terms of side effects than R-CHOP.
For sure. And then here's a great question. Have you been delaying antibody use in diffuse large B-cell lymphoma because of COVID-19? Amy, have you guys been doing that?
We have not. We have not. We have done that more in the low grades and CLLs, but we just talked about 60% of patients being cured with their initial therapy. So when you're treating with curative intent, certainly delaying antibody use is not something that we're doing. And even in the relapse refractory setting, we are trying to get those long remissions. And these are folks who don't do well sitting without effective therapy. So it's kind of a slippery slope to think about delaying any treatment for these patients.
Exactly. It's not really an option for them. You just have to really focus on, at least over the past year or so, focus on making sure they're being safe and that their families are being safe, that the family members are not, increasing their exposure and bringing it into the house, bringing it into the home. And now that we have the vaccine, it's focusing on, getting the family members vaccinated, because some of these patients, we want them to be vaccinated, but they may not respond, right? So, okay, so now moving on to changing practices, the nurse's role in delivering effective antibody therapy in diffuse large B-cell lymphoma. So here's Nathan. So Nathan is preparing for therapy with Tapacidomab and lenalidomide. What should he expect? Well, some of the educational points to discuss with him would include, of course, timing of therapy and duration of infusion. All the patients want to know how often do I have to come here, and also how long is therapy? So the dosing schedule, how long am I going to be on therapy? He should know he will be on therapy till progression. And then, of course, the side effects to watch out for. And so we want to watch out for infections, infusion reactions, and myelosuppression are some of the more common. And with lenalidomide, really common side effects include diarrhea, rash, and thromboembolism. So if he's not already on some sort of anticoagulation, he probably is if he's got atrial fibrillation, but you want to double check and make sure he is. If he's not, I know we usually make sure that they're at least taking a baby aspirin as a prophylaxis. Let's see, we'll move on. So antibody dosing, approved agents. So this is Tapacidomab. I love this table. It just lays it out so nicely. One thing to really focus on with patients is with Tapacidomab would be to let them know that first cycle is sort of a loading dose cycle, really cycles 1 through 3. So in cycle 1, they're getting it day 1, day 4, day 8, day 15, and day 22. So they're going to be in the clinic a lot. And that's a big part of the teaching, right? Is, okay, you're going to be here a lot and you're going to be sick of us. But by cycles 4 and beyond, you're coming every 2 weeks. And so that's something to really focus on with patients, is to kind of give them that sort of light, because they are going to be tired of coming into the clinic. Jill, what would you have to say about patients and talking to them about timing of therapies?
I think the biggest key is just education, Camille, and maybe if you have something that is written that you can provide to them, that's going to be extremely helpful. I know a lot of times either there's no family member with them because of COVID restrictions, or maybe that family member wasn't able to come, or there's another one at home that's going to have a lot of questions, and just providing the patient with good information, but then providing the patient something to take home with them, and then giving the patient all the contact information they need for, if your family member has questions, here's the number to have them call, and then watching what to watch for at home. Watch for fevers, and like you mentioned with the diarrhea, we usually do if you're having more than 6 episodes a day, or maybe a few less than that, kind of depending on how they judge it, to give the office a call sooner rather than later.
Thank you, Jill. Yeah, absolutely. Our nurses are amazing. Y'all are amazing at giving calendars to the patients, especially patients that have a lot going on. Maybe they don't have a caregiver with them. And that's been really challenging, I think, during COVID, is not, at least in our clinic, not having family members in the treatment room. So, our patients that really have to have somebody with them have to go to a special room, but everybody else is coming back there. And I know that definitely has been a challenge. So definitely something written is helpful for them. Also to note, this is in combination with lenalidomide. They're going to have lenalidomide. It's 25 milligrams per day on days 1 through 21 of a 28-day cycle. So they get a week off. Obviously, you're going to watch for kidney function when this is dosed. Our pharmacy is really good about making sure that those are dosed appropriately. So you may need to dose reduce them if they've got some CKD. Also, they're only on the lenalidomide. I wanted to add this in for a year. That's another teaching point for the patients, is that they'll be on the lenalidomide for 1 year, and then they'll be on the Tapacidomab until progression. So premedication is recommended with Tapacidomab, 30 minutes to 2 hours prior to starting the IV infusion, in order to minimize reactions. Of course, you'd want to give acetaminophen, maybe a histamine, H1 receptor antagonist, a histamine H2 receptor antagonist, or steroids. For patients not experiencing infusion reactions during the first 3 infusions, you can then decide whether or not that they need it. For Polatuzumab Bedotin, this is 1.8 milligrams per kilograms IV over 90 minutes every 21 days for 6 cycles in combination with bendamustine and rituximab. Subsequent infusions may be administered over 30 minutes, so it's not as long of a chair stay. They also need to be premedicated with an antihistamine and an antipyretic before infusion. Okay, so Nathan is responding well to the Tapacidomab and lenalidomide, but he experiences toxicity during cycle 3. So he comes in for a nurse visit, and they've noticed that his neutrophil count has fallen to 400 over a week-long period. So what would be the appropriate intervention? How would you guys Amy, how would you guys manage this?
Well, I mean, certainly holding therapy is where you start. And because his neutrophil count is so low, starting him on a broad spectrum antibiotic would definitely be in order. And then really just having a plan for watching his counts closely. And of course, this is a great teaching moment. So he's taking his temperature and looking for signs and symptoms of infection. But really the short term is stop the drug, get him on some antibiotics, watch him closely, and then depending how long it takes for him to recover, you would figure out if you were dose reducing or what you were going to do from there. But for the here and now, just stop, get him covered, keep him safe, and monitor.
Do you start diflucan on these patients, or do you just see how they recover?
So, it depends who the patient is, what is this second or third line, or is this really fourth, fifth, sixth line? So some of it is who is the patient in front of us. Some people were very quick to just cover everything. And some folks, if they're not particularly heavily pretreated, just that broad spectrum antibiotic may be enough for them. But again, this is where it's preference. It's all tailored to the patient in front of you.
Absolutely. Yeah. Also, the antifungals interact with everything, and they're expensive.
Yes.
So if we don't have to put them on it, obviously some of them need it, but if we don't have to,
Yep.
if we think they're going to recover, then we don't put them on it.
Yep.
So hold therapy. What's the appropriate intervention? Hold therapy, start daily levofloxacin or some other broad spectrum antibiotic. Monitor the CBC weekly until the neutrophil count is over 1,000. And then we would resume the therapy at the same dose and reduce the lenalidomide dose. So most common grade 3 AEs with Tapacidomab and lenalidomide was neutropenia, like we just talked about, at 48%, and thrombocytopenia and febrile neutropenia. Lenalidomide particularly is pretty notorious for causing neutropenia. We have to dose reduce that quite a bit in some of in our older patients, and so in combination with the Tapacidomab, you can see why it's a grade 3 or higher situation. So you've really got to watch these patients. And serious AEs occurred in 41 of 81 patients, and they included pneumonia at 6%, febrile neutropenia at 6%, pulmonary embolism at 4%, bronchitis, atrial fibrillation, and congestive heart failure at 2% each. And so, of course, this is another instance where patients just obviously need to know to call for fevers. They have to know to call the clinic for fevers. Safety monitoring recommendations with Tapacidomab are infusion-related reactions. So we want to monitor the patients frequently during the infusions and interrupt or discontinue the infusions based on severity. Myelosuppression we just talked about. We're going to monitor their CBCs closely and manage with dose modifications and growth factors if necessary. And of course, we're always monitoring these patients for infections because they're at risk for infections, just honestly by the nature of their disease. So in the infusion-related reactions, I would say at the clinic that I'm at, I mean, the nurses do an incredible job of managing this. I mean, they manage these. And so usually if they come and get me, I know something is really wrong. They've usually already stopped the therapy, given extra steroids. Amy, when do they get you involved? Like, is it usually when things are pretty progressed if there's a reaction, or do you have to sort of help manage every reaction?
So we actually have an urgent care, and there's an NP in our urgent care. So they tend to, I tend to get the call first, and then if things progress, they grab the urgent care nurse, NP, to help, with figuring out if the patient needs to be admitted or, what we need to do with them. But certainly the oncology nurses who do this all the time, I frequently will say, okay, what do you think they need? Right. So just this week, I had a patient get admitted after an antibody infusion because we couldn't get her off oxygen. But one of the things the nurse was saying was she's really anxious. I think some lorazepam would help. Like, yes, that's fine.
Yes, let's do that.
Because those are things that I don't know. I'm not there. I'm usually, on another floor seeing patients. So, I mean, this is where our oncology nurses really shine, and they make patients feel so comfortable, which is so awesome.
Absolutely.
Yeah.
Absolutely. Yes. Okay, so Polatuzumab Bedotin safety in relapse refractory diffuse large B-cell lymphoma. Pola and BR compared with BR showed higher rates of grade 3-4 AEs. So you had greater rates of neutropenia at 46% versus 33%. And this is not surprising. We add another agent, even though it may, obviously it works better, you may have some higher AEs in certain areas. Anemia, 28.2% versus 17.9%, and thrombocytopenia. So again, at least weekly, I would say CBC checks until you know how their counts are going to respond, and then sort of back off is sort of what we would do. And then the neuropathy with some of the antibody drug conjugates, it's very easily manageable if they're telling you about it. So it's really important to make sure that patients are talking about changes of sensation, or this is another place where nurses really shine, because they'll notice that the patient didn't walk in the same way, or even those or the family members tell us so much information that sometimes the patients don't. And so most of the peripheral neuropathy with polatuzumab was manageable at grade 1 or grade 2, but it can come on quickly, and we really want to prevent it from getting to grade 3. So safety monitoring recommendations with Polatuzumab Bedotin, peripheral neuropathy, just like I was talking about. Infusion reactions, make sure we get those premedications in, especially those first doses. Myelosuppression, bacterial, fungal, and viral infections, and PML. So this is very rare, but it is, you want to monitor patients for new or worsening neurological, cognitive, or behavioral changes. And other monitoring recommendations, of course, if there's a patient with high tumor burden, they have really bulky disease, then they may need some tumor lysis prophylaxis, just Q24, they may need to come back for labs and fluids the next day just to make sure that they're not going into tumor lysis, their kidney function's okay. And of course, we always want to watch for hepatotoxicity. All right, so nursing clinical consult, we're going to reimagine Nathan's case. So if he was eligible for a clinical trial or elected to pursue trial-based therapy, what would the role of the nurse be in developing or implementing a care plan? Jill?
Thank you, Camille. So let's just look then at what would it look like if Nathan and his family chose that clinical trial participation would be right for him. So just as a reminder, patient has diffuse large B-cell lymphoma. There are several comorbidities that would come into play that may limit the number of clinical trials that Nathan can participate in. So that would definitely be something to be considered. And then, so here at our site, what happens is the physician will go over potential treatment options with the patient. And then if a clinical trial is one of those options that they feel is the best choice for this patient, they will then involve the enrollment team and the clinical trial team here at this site. So then I go and meet with the patient, either here in the clinic or by telemedicine, give them a copy of the consent, give them teaching sheets that kind of summarize what it would look like if they participated in the clinical trial. I love it when the family is here with them if possible. Sometimes the patients are getting their family on the phone or that kind of thing as well, but I'll leave them with just good general information and then my contact information for them to take home and look over at least overnight before I give them a call and just see what decision they've made. Then the next step would be to bring the patient in for a consenting and screening visit. So depending on the clinical trial, there's different requirements that come in for screening, usually including things like biopsies, scans, labs. So usually the patient will come in, meet again with the physician for any final questions, and then we'll sit down with the consent and go through that, of course, prior to any of the screening procedures being done. Then all of the information is analyzed from the screening to confirm that the patient's eligible. Then we schedule to come in for a treatment visit. Again, educating the patient at each one of these steps. There's multiple conversations that take place. Treatment then often includes multiple blood draws and extensive monitoring after. And again, with the monoclonal antibody drugs, sometimes there's a hospitalization involved or several hours in the clinic for patient safety. Just kind of a note about CAR T trials. There's different kinds of CAR Ts. There's the autologous, where the patient has their cells collected. Those are then manufactured, usually taking 4 to 5 weeks, and then they're ready to be reinfused. There also are available allogenic CAR T cells that are off the shelf or from a donor that we can give these patients as well. So kind of depending on what the physician feels is best for them and where they are in their treatment journey. And then a few considerations for local physicians' offices as well. If you have your patient coming to be evaluated for a clinical trial, things to definitely think about would be blood transfusions, administering erythropoietin, or other like a GCSF type drug. Also need to be careful with the prescriptions that are given to these patients. So giving them a prescription for an antibiotic or a steroid may affect the timing of the clinical trial, and it would have to be delayed. So I think big thing is to communicate with the clinical trial site if your patient is being screened for a clinical trial. A few things that often run into questions from patients and their families. There is common misconception that study pays for all medical care and assists with living expenses while the patient's participating in clinical trial. While a patient is on study, their insurance will still need to pay for all of the standard of care things. So making that very clear to the patient and their family from the start is very important. Then studies will allow or will help pay for a lot of times hotels or things like that around the clinical trial visits, but that is very limited and then depends on the specific trial. Another question that I often get from patients and their families is, how do I know if I'm getting a placebo or not? If there are placebos involved in the trial, it will be very clear in the consent that the patient signs. So that's something definitely to educate or use as an educational point. So for Nathan, some of the antibodies that the physician may consider giving him as a next line of therapy would be the Lonca drug. This is an ADC or an antibody drug conjugate comprised of humanized anti-CD19 antibodies. And it's conjugated to a potent PDD dimer. And then the LOTUS-5 trial was the one that tested this drug in combination with rituximab versus the chemotherapy in patients with relapse refractory diffuse large B-cell lymphoma. Another option that the physician may consider would be the Mosin drug. That is a CD20, CD3 BiTE that's currently being tested in follicular lymphoma and other non-Hodgkin's lymphoma, including diffuse large B-cell. So for Nathan, the physician chose the Lonca drug. So again, a big piece of that's very important for him would be educating him on the schedule that will, the schedule of drug administration, so that way he knows what he's committing to. So this drug was tested in a phase 2 study of 145 patients with relapse refractory diffuse large B-cell lymphoma following greater than or equal to 2 lines of prior systemic therapy. So this involves a 30-minute infusion every 3 weeks for up to a year. And then after that, they can transition to dosing every 12 weeks for up to 3 more years. Again, these patients would just continue treatment until they progress. So with the Lonca, the phase 2 trial, the overall response rate came back at 48.3%, with complete response being at almost 25%. Most responders had, patients that were going to respond had a response after 2 cycles. The median time to the first response was 41 days. So this is extremely encouraging for our patients because a lot of them are heavily pretreated or have very difficult to treat diffuse large B-cell lymphoma, with it being double or triple hit. So especially seen with a good response rate in patients with prior CAR T-cell therapy or patients with greater than 3 lines of prior therapy. The most common grade 3 AEs that we're seeing were neutropenia in 26.2%, thrombocytopenia 17.9%, an increase in the GGT at 17.2%, and then anemia in 10.3% of the patients. Thankfully, there was no increase in toxicity with patients over 65 years old compared to younger patients. So Mosin is a BiTE active in diffuse large B-cell lymphoma, and they are seeing complete responses in up to over 20% of the patients with highly refractory non-Hodgkin lymphoma, especially in patients that are heavily pretreated or even ones that are progressing after receiving CAR T-cell therapy. Adverse events to note include CRS and neurotoxicity. So again, very important to educate patients and their families about what to watch for at home and notify the physician's office of immediately. This is an FDA breakthrough designation for relapse refractory follicular lymphoma and continues to be assessed in diffuse large B-cell lymphoma setting as well. So finally, Nathan decides to enroll on a trial with a novel antibody drug conjugate and has questions about the protocol. So the education of these patients and their families never ends. During one of the clinic visits, he asks questions about transportation to the clinical site and if there is any help available, and then lifestyle and financial impacts. So there are some resources that can be pulled in to help them through like American Cancer Society and things like that, but unfortunately it is limited. Safety monitoring and hospitalizations are often an ongoing question. The question of how long I have to stay in the clinic and why do I have to come every week? And then timing of follow-up for data collection. So it is very important with clinical trials that the data be collected at the time points needed for the assessing of the drug and the safety monitoring of the patient. And then I think we're back to you, Camille.
Thank you so much, Jill. So just to summarize everything we've been over, here's some take-homes on novel antibodies. Novel antibodies are effective and well-tolerated options for patients ineligible for transplant or CAR T therapy. They offer a chance for longer life and better quality of life over multi-drug chemotherapy intensive regimens in refractory patients. Even with the high response and overall survival rates at this point, they are still considered palliative and not curative. And side effect management and education is crucial in keeping patients on therapy and for the best chance of response and increased survival. So we got some more questions coming in. We got some more good ones. One is, what do you recommend for mitigating infection risk with antibody therapy in diffuse large B-cell lymphoma? Amy?
Right, and so we talked about this a little bit earlier, Camille and Jill, and it really, some of the antibodies do carry a higher risk of infection. And I am constantly going back to the NCCN guidelines and looking at infection, what the NCCN is recommending. We also have much of this embedded in our chemo plans, our treatment plans, but you're always thinking about PJP, and you're thinking about herpetic and varicella outbreaks, and you're thinking about fungal infections, particularly in these patients who have received a lot of therapy, potentially post-transplant or post-CAR T, and really covering folks like that much more aggressively versus, when you're using it in the second line. So it's always something that you're thinking about, always something that you're evaluating. If the drug doesn't have anti-infectives recommended, you need to tailor to the patient.
Thank you. And then, let's see. Jill, I'm gonna give this question to you. Do you always recommend talking to patients about clinical trials? Many patients can be hesitant when the subject comes up. What do you say about that?
I think that it's in a lot of settings it's not discussed enough. But I think that it's also very important for the physician to have kind of the initial conversation with the patient, so that way they are prepared for the conversation when it comes to the enrollment team and the research team, to have that, just to have that groundwork laid by the physician. And then, we do talk with a lot of them and they decide not to participate. They decide that they can't maintain that visit schedule, or it's not going to work for them. But at least then you planted the seed in their mind, and they know that might possibly be an option in the future if they choose to participate at that time.
Thank you and have a good day.
This activity is accredited by Medical Learning Institute, Incorporated. This activity is developed with our educational partner, PVI, Peer Review Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/DFX860. This activity is supported by educational grants from ADC Therapeutics America, Incorporated, Insight Corporation, and Morphosis, Incorporated.